Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Brian Worden. He's an otolaryngologist. Today's Kevin MD article is The Surprising Link Between Migraine and Tinnitus. Brian, welcome to the show.
Hey, thanks for having me. It's a pleasure to be here.
All right, so before talking about your article, just briefly share your story and journey.
Okay. Well, I grew up mostly in California. I went to college in California. I went to medical school at the University of California, San Francisco, and I did my residency training in otolaryngology at Stanford. And I've been a practicing otolaryngologist based in Southern California since about 2009. And in recent years, I've been particularly focused on improving the care for people with intrusive tinnitus.
All right, and tell us about the article for those that didn't get a chance to read it, The Surprising Link Between Migraine and Tinnitus.
Yeah, so I'll give you a little bit of background first. One of the things that really stood out to me relatively early on in my clinical practice was the lack of available resources and treatment options for people that have intrusive tinnitus. And that word tinnitus, for those of you who aren't familiar with it, refers to a perception of sound when there's not actually a sound in the environment. So a lot of people call it ringing in the ears, but the sound could be a buzz, it could be a hiss, it could be any number of sounds actually. And tinnitus is usually associated with hearing loss, and it's quite common. It probably affects close to 20% of the population. And unfortunately, for the majority of people that have tinnitus, it's an annoyance, it's bothersome, but it's not a huge issue. But there is a subset of people that have tinnitus, maybe 5% to 10% of people that have tinnitus that find it so intrusive and so disruptive that it ruins their quality of life. And the general consensus for many years among the medical community was that there just weren't good treatment options for people with tinnitus. And I know that personally, I did not receive a lot of education about tinnitus in medical school or even in residency. We didn't talk that much about tinnitus. So when I found myself in independent clinical practice and I was meeting these people in my clinic that were telling me about how their tinnitus was ruining their life, I was really woefully underprepared to help these people. But I could see how much that the tinnitus was really causing suffering. And so I spent a lot of time digging deeper into the topic, looking into the clinical research and talking to experts to see what kinds of things really were out there to help people with tinnitus. And what I discovered was that there actually is a literature on this, and that there are a number of strategies that have been shown in clinical research to reduce the severity of tinnitus, reduce the burden of tinnitus, even a number of randomized controlled trials. And the techniques that tend to work include things like specialized forms of cognitive behavioral therapy that are tailored for tinnitus, mindfulness techniques, certain forms of sound therapy. There's something called tinnitus retraining therapy, and a few other strategies. And so after I discovered that there were these treatments that were available for people with tinnitus, I was feeling a lot more optimistic. And I started looking around my area in Southern California for places that I could send my patients that had tinnitus to help them out. And what I discovered was that there are literally only a handful of places in the whole country that offer evidence-based treatment for patients that have tinnitus. And it's probably because of insurance reimbursement. It's often not covered by insurance. It's not well reimbursed by insurance companies. So there's not a lot of places that offer that kind of treatment. So that motivated me to create a multifaceted evidence-based treatment program for patients with tinnitus at my own medical center in Southern California. And after doing that for a while, we saw some really encouraging results. A lot of patients were really finding benefit from the techniques that we were employing. And from there, we developed a website and an app-based program for people to expose even more people to the opportunity for these kinds of evidence-based treatments. And one thing that became clear to me after treating a lot of patients with tinnitus was that there was a subtype of tinnitus sufferer that had symptoms that were a little bit different.
Mm.
So the typical patient with tinnitus tends to be somebody that has hearing loss, maybe somebody that's a little bit older, that's had some loud noise exposure in their life, and their tinnitus is rather constant. It's a tone or a buzz that's there all the time. Maybe it's a little bit louder when they're in a really quiet environment, but otherwise it's pretty stable. But again, there's this subtype of patients that have tinnitus that are a little bit different, and they describe intermittent tinnitus or tinnitus that fluctuates pretty significantly in either character or volume over the course of a typical week. And oftentimes they describe that their tinnitus may get worse if they're stressed, or if they're not well rested, or if they're hungry, or other factors like that, maybe even dietary factors. And so I found this rather curious. And so again, I found myself looking into the clinical literature to see if there are other people out there that have described this phenomenon. And sure enough, I came across some other specialists, Dr. Michael Teixeira, Dr. Hamid Jajilian, who had described a variant of atypical migraine in which patients were actually predominantly reporting ear-related symptoms. And it's been called cochlear migraine or otologic migraine. And one of the symptoms that these patients oftentimes report is fluctuating tinnitus. And that made a lot of sense to me because I was already in my practice seeing a lot of patients that have atypical migraine because they were coming in to see me with things like unexplained ear pain or unexplained ear pressure, or ear fullness, episodic vertigo, or even like sinus type headaches, despite having no objective inflammation in their sinuses. And so what I started doing, and several other specialists across the country started doing, is treating these patients that have fluctuating tinnitus, this subset of patients with tinnitus with migraine-specific therapies. And we started seeing that these patients, many of them, were actually seeing improvements in their tinnitus. And so the purpose of the article that I published at Kevin MD was to kind of spread the word about this, to let clinicians know that this is something that should be on their radar, and to let even patients know if they are somebody that has fluctuating tinnitus, that this is something that offers a parallel treatment pathway, something else that might actually help out with their symptoms.
So how about in the primary care setting? So tinnitus is a relatively common complaint that people come in with in my own clinic. So what are some clues to the story I should look out for to see whether tinnitus is part of that variant that you just described?
Yeah, that's a great question. First of all, I think for people in primary care, I think asking a couple of questions to their patients with tinnitus first, just as a screening, can help differentiate somebody that has just typical tinnitus that's no big deal from somebody that has tinnitus that's really affecting their quality of life. So just asking them how much it bothers them. Is it something that interferes with their normal functioning? Is it something that's making them feel anxious or depressed? And for people that just say, oh, no, it's just kind of annoying, but most of the time I can forget about it. Those kinds of patients, they probably don't need any sort of evaluation other than maybe a hearing test. But for people that have tinnitus that's really intrusive, that's really, really bothersome, that's eroding their quality of life, those people should be seen by an otolaryngologist and have a full evaluation to see if there is any sort of readily reversible cause of tinnitus, and perhaps plug them into different treatment options, right? But with regard to migraine-associated tinnitus, there are a few clues that somebody with tinnitus may display that gives you an idea that migraine may be contributing to their tinnitus and that perhaps migraine-specific therapies would help. So one of them, as I mentioned earlier, is fluctuating tinnitus. So if somebody says that their tinnitus is coming and going on a daily basis, or that some days it sounds like a tone, and some days it sounds like a jackhammer, and some days it's soft, and some days it's loud, that is a clue. If somebody has other symptoms other than just tinnitus, other ear-related symptoms, so if they have also intermittent ear pain or intermittent ear fullness, if they have episodes of spinning vertigo or other kinds of dizziness, if there's a family history of migraine, or other symptoms like that. Those can all be clues that somebody may have migraine contributing to their tinnitus pathophysiology.
So when we send a patient with tinnitus to an otolaryngologist like yourself, just tell us what you do with them in the office in terms of tests you may or may not order. Just take us through the diagnostic process once we refer these patients to you.
Yeah. I mean, I think when we see somebody with tinnitus in the clinic, the first thing that we're doing is we're taking a very thorough history. So we want to know about their tinnitus. They have them describe their tinnitus, when they're experiencing their tinnitus, how much their tinnitus is affecting their quality of life. And then we're asking about other symptoms that they have, other ear-related symptoms. Are they having headaches? Are they having dizziness and vertigo? Are they having things like that? Do they have a history of loud noise exposure, other sorts of ear pathologies, and so on and so forth? And after we get a good history, then we're going to do a good physical examination of their ears, because we want to see, is there something going on here that may be contributing to their tinnitus that we can actually fix, something that's like readily reversible? Do they have a cerumen impaction that's touching their eardrum, and we just remove that cerumen impaction, that makes their tinnitus go away? Honestly, I've had patients like that, and they're very satisfied because you actually fix their tinnitus in one visit. Do they have temporal mandibular disorder? Because temporal mandibular disorder is definitely something that can contribute to tinnitus. And for many patients, just properly treating the temporal mandibular disorder can improve their tinnitus. Do they have a migraine disorder, as we're talking about today? And if so, doing things in the realm of treating their migraine disorder has potential to improve their tinnitus. Or is there some other medical condition that we should be aware of that needs to be managed? Do they have chronic otitis media that we need to treat medically or surgically? Do they have eustachian tube dysfunction? Do they have chronic sinusitis or something like that also that we can manage that has some potential at improving their tinnitus? And then on top of that, they're going to have a thorough hearing test with an audiologist, because as I said, the majority of people that have tinnitus have some degree of hearing loss. And for many people, if we fit them with well-programmed digital hearing aids, just that can make a big difference with regard to their tinnitus, because we're amplifying a lot of those frequencies that their ears are missing. And then by amplifying those frequencies, oftentimes it kind of masks the tinnitus and makes it less noticeable and bothersome for those patients.
When it comes to these fluctuating migraine-related tinnitus, is that diagnosis made purely based on the history? Are there any specific diagnostic tests that can objectify that finding?
No, not really, unfortunately. There's not a blood test or an imaging test that's going to show us conclusively whether somebody has migraine-associated tinnitus. So it's a diagnosis of exclusion, or ruling out any other causes that could produce those kinds of symptoms. And as I said, there are some clues just based on their history. But just like any other migraine disorder or migraine variant, oftentimes it's a process of trial and error, where we think, well, maybe this is migrainous. Let's try out some migraine therapy and see if it helps, right? And there are a variety of things that we can do in that realm, ranging from lifestyle modifications, migraine trigger avoidance strategies, to nutritional supplements, even to migraine prophylactic medications.
So talk about some of those management approaches. So when you talk about lifestyle in your article, you talk about even something as simple as diet, right? That can make a difference.
Yeah, yeah. I mean, that's the thing about migraine, is that we think that migraine in most people is a genetic predisposition. So it tends to run in families. It probably, for most people, is related to ion channel variants that they have inherited, and they have, because of that, a lifelong predisposition to migraine. And whether or not they have migraine symptoms is going to depend on what physiologic state their body is in and what kinds of exposures their body is exposed to. And there are a number of well-documented triggers that we know tend to provoke migraine activity. And the thought is that they cause some increased neuronal activity that can, under certain circumstances, push somebody over this threshold that then triggers migraine activity. And there are a number of different kinds of treatment. So we know as far as physiologic states, when people are tired, if they're sleep deprived, they're much more likely to have migraine symptoms. Stress is probably the number one trigger for migraine symptoms. Hormonal fluctuations, things like the menstrual period or pregnancy or menopause can be a big factor. Hunger, dehydration, those are big factors for migraine as well. There are certain foods that can be triggers for migraines for a number of people, and probably the most common ones would be things like chocolate and red wine and caffeine, aged cheeses, processed meats, and things like that. And for a number of people, if they can eliminate those kinds of foods, or at least minimize those kinds of foods from their diet, that can have a hugely beneficial effect on their migraine symptoms. And then for some people, it's a sensory overload. So some people can have migraine triggered by looking at the sun or really loud sounds or really strong odors. There's even people that tend to be sensitive to changes in barometric pressure. So they'll have migraine with weather changes, or they'll have migraine symptoms when they fly on an airplane. And those are some of the kind of classic lifestyle and environmental factors that can influence migraine. And so when we're approaching somebody that we think has migraine influencing either tinnitus or other symptoms, we're going to educate them about these kinds of dietary and environmental triggers and encourage them as much as they can to try and minimize their exposure to them. And obviously some of those things are easier to avoid than others, but even just focusing on getting good quality sleep, treating unrecognized sleep apnea, trying to manage stress in healthy ways, and minimizing exposure to some of these foods can be hugely beneficial. Another really low risk thing that we recommend to a lot of our migraine patients are some dietary supplements. So things like magnesium and vitamin B2, coenzyme Q10, and even melatonin can be helpful for patients with migraine. And then if those low risk strategies are not effective enough at reducing symptoms, then there are medications. And migraine medications tend to fall into two major classes. There's the abortive medicines. The abortive medicines really are more for the headache type symptoms of migraine. So you start feeling a headache and you take your triptan, and that can shorten the duration of the headache, maybe make the headache less severe. Those are less applicable to these kinds of otologic symptoms that we're talking about. Generally, if we're going to use medications for somebody that has ear symptoms related to migraine, we're talking about taking a prophylactic medicine. And that means taking a medicine every day to try and prevent those migraine symptoms. And the thought is that the medication is raising that neuronal threshold so that it's harder to reach that threshold that triggers migraine activity. And there's a number of different medication classes that can be helpful for migraine prophylaxis, ranging from calcium channel blockers to beta blockers, tricyclic antidepressants, serotonin and norepinephrine reuptake inhibitors, and anti-epileptics like topiramate. And now there's even the newer, more expensive CGRP inhibitor type medications.
We're talking to Brian Worden. He's an otolaryngologist. Today's Kevin MD article is The Surprising Link Between Migraines and Tinnitus. Brian, let's end with some take-home messages they want to leave with the Kevin MD audience.
Sure. So for the clinicians out there, my message is that please don't underestimate the negative effects that intrusive tinnitus can have on our patients, and know that effective tinnitus treatment does exist and that it's becoming more accessible as treatments are being migrated into the virtual space. And if you don't have a center in your geographic area that's offering quality evidence-based tinnitus treatment, please consider directing your patients to a website, www.alleviatetinnitus.com, where they can access a free, thorough instructional workshop on the subject that I've put together, and that can get them plugged into some helpful evidence-based treatment strategies.
Brian, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thanks for having me. It's been great.